Thank you, Zoom colleagues, for joining us. Dr. Montroque, Dr. Lewis, Luca, can we please test your audio and video?
Thanks. Everything look okay to you?
It's good, a little low levels here, but we can see if we can boost that. Rosamund, do you hear us okay? You're muted, I think, Rosamund, or you're not sending any audio. You're unmuted now. I'm just not hearing anything from you.
Very soft.
Laurent, si tu m'entends, est-ce que tu peux booster le Zoom audio dans la salle, s'il vous plaît? Luca, ciao. Do you hear us okay?
Yeah, I do hear you well.
That's very good, thank you. Your audio is nice and clear. Lighting, on the other hand, oh la la, these rooms that you use, awful. You might want to also, if you can, raise your if you're on a laptop, just raise it up a little bit so it's kind of at your eye level. It's coming a little bit low, if you can. If you just throw a box or something underneath it, just get it up a little bit more like that, you know, if you can do it. Rosamund, let's check you. Audio test. Yes. Do you hear us okay, Rosamund? Yes, but we still can't hear you.
Okay, I'm going to go to my phone.
Wow, very low.
Speak soft, carry a big stick.
And Joshua, you're a little bit low too, to be honest with you, compared to Lucas.
Okay, let me
just either talk louder if you have to talk, or.
Is this okay?
That's better. That's much better. Thank you.
Okay.
Thank you, Luca. Your big effort. We appreciate that. I'll give it a few more minutes. Dr. Gaspar, do you hear us okay? Rogerio, audio test for.
Is my hair okay?
You're very good.
Okay.
Teresa, do you hear us okay? Dr. Gaspar, I see you. And Teresa, I hear you. So we're gonna have to open this up soon, so let's try to finish our test quickly. It's 3 o'clock. Can you see if any news on when they're coming? Start time. Derek or someone else from Leg on Derek's account there. I see your connection, but don't have any audio from you. I'm gonna mute you, Joshua. Rick, we need Rick.
Okay, I'm here.
Oh, a little bit of an echo there from you. Oh. Maybe you have two audio. Do you have two? You're echoing a little bit, Rosamund. Maybe just turn, I don't know why, but you are.
Is that working yet? No.
Yeah, maybe you have two connections now then? So just maybe drop your audio on your, probably if you have your laptop sound on still and you're sending us the audio from the other one, it's looping. And there's Rick. Hello, Rick, do you hear us okay?
Yeah, I can hear you. Yeah, I can hear you well. Thanks.
Nice to see you, Rick. We're almost getting ready here. We're still in the practice mode, which is waiting.
Okay.
I think we don't have any update on our start time.
So is this okay now? I've got
Yes, that's much better, Rosamund. Thank you.
video on laptop and audio on phone.
You're a master of technologies there.
Hey, thanks.
Okay, so if everyone's okay, we will open up the Zoom now, I think. So
My camera is clear?
your camera is very clear. Little teeny bit too much headroom. If you could tilt down ever so slightly your camera, Rick, that would be fantastic. Ever so slightly. Or come in a little bit closer, one or the other. Perfect. That's perfect. Thank you so much. Okay, so let's mute our microphones, and I'm going to open up the webinar in about 15 seconds, and we'll try to update you in the chat as to our actual start time. Still waiting for Dr. Tedros and Mike here in the room. Thank you, everyone, for joining, and good luck to everyone.
Hello all, I am Fadila Shaib, talking to you from WHO headquarters in Geneva. I would like to welcome you to our virtual press conference today, Wednesday, 3rd April, on global and humanitarian issues. Let me introduce to you a participant in the room. We have Dr. Tedros Adhanom Ghebreyesus, WHO Director General, Dr. Mike Ryan, Executive Director of WHO Emergencies Program. We have also Dr. Jawad Mahjour, Head of the WHO Secretariat to INB and AHR Amendment. And we have also the pleasure to welcome Nikanin Ritaroli Polina, Senior Technical Lead on Human Rights, to talk about World Health Day. We have also with us Dr. Rick Pieperkorn online from Jerusalem. He's the WHO representative for the occupied Palestinian territory. We have a number of other WHO experts that I will be introducing if there is a need for them to speak to you. So without further ado, I would like to hand over to Dr. Tedros for his opening remarks. Dr. Tedros, you have the floor.
Thank you, Fadila. Good morning, good afternoon, and good evening. First, to Gaza. WHO is horrified by the killing of 7 humanitarian workers from World Central Kitchen in Gaza on Monday. The work they were doing was saving lives, providing food to thousands of starving people. Their cars were clearly marked and should never have been attacked. Delivering humanitarian aid in Gaza is already difficult and dangerous. Hungry people will go unfed because World Central Kitchen has quite understandably paused its operations. I honor our colleagues for their service and for putting themselves in harm's way to serve others. WHO has been working with World Central Kitchen in Gaza to deliver food to health workers and patients in hospitals. This horrific incident highlights the extreme danger under which WHO colleagues and our partners are working and will continue to work. But we can only do so with safe access. This means an effective and transparent mechanism for deconfliction must be put in place to ensure humanitarian convoys can move safely. We need more entry points, including in northern Gaza, cleared roads, and predictable and expedited passage through checkpoints. Delays and denials of humanitarian missions not only prevent us from reaching those in need, but also impact other operations and deliveries by diverting scarce resources. In addition to the attack on World Central Kitchen convoy, we're likewise appalled that Al-Shifa Hospital has been put out of action and that much of it has been badly damaged or destroyed. Over the last few days, WHO's team in Gaza has been seeking permission to access what is left of the hospital, to speak with staff, and to see what can be saved. But at the moment, the situation looks disastrous. Al-Shifa was the largest hospital and main referral center in the Gaza Strip, with 750 beds, 26 operating rooms, 32 intensive care rooms, a dialysis department, and a central laboratory. I repeat, hospitals must be respected and protected. They must not be used as battlefields. Since the conflict began, WHO has verified 906 attacks on healthcare in Gaza, the West Bank, Israel, and Lebanon, resulting in 736 deaths and 1,014 injuries. Only 10 of Gaza's 36 hospitals are still able to function, even partially. WHO will continue to support those hospitals to deliver services as best they can. More than 33,000 people have now been killed in Gaza and almost 80,000 injured. We're seeing a very high burden of respiratory and skin infections and diarrheal illness. This Sunday marks 6 months since the conflict began. WHO welcomes last week's UN Security Council resolution demanding a ceasefire, and we call for its immediate implementation. Once again, we call for all hostages to be released and for lasting peace. Now to the Democratic Republic of the Congo, which is experiencing a severe outbreak of mpox. More than 4,500 suspected cases and almost 300 deaths have been reported so far this year, triple the numbers of cases and deaths reported in the first quarter of last year. 19 of DRC's 26 provinces have reported cases, and 70% of cases and 87% of deaths are in children under 15 years of age. While mpox is spread among children by close contact, there is also a concerning outbreak among adults due to sexual transmission in previously unaffected areas. These outbreaks are being caused by clade 1 of the virus that causes mpox, which has been present in DRC for decades and can cause higher mortality than the clade 2 virus that spread globally in 2022. WHO and our partners, including Africa CDC, are supporting the Ministry of Health to respond to the outbreak and to assess mpox vaccines. However, additional funding is needed to expand and sustain the response and ensure the virus does not spread to neighboring countries. WHO has called consistently for more attention to better understand and stop mpox transmission in Africa and to improve clinical care and access to vaccines. At its meeting last month, WHO Strategic Advisory Group of Experts on Immunization, SAGE, also issued a call to action to enhance access to mpox vaccines, to improve regulatory and procurement processes, to ensure research is embedded in emergency vaccine deployment, and to invest in research capacity in Africa. The mpox outbreak is one of several overlapping crises in the DRC. There are also outbreaks of measles and cholera, severe flooding in more than half of provinces, and since the beginning of this year, more than 350,000 people have been displaced, mostly because of armed conflict. Now to the United States, where the US CDC has confirmed one case of H5N1 avian influenza in a person who works at a commercial dairy farm. The patient did not report any symptoms apart from eye redness, was not hospitalized, and is recovering. Investigations are continuing into how the person was infected, and WHO is in close contact with the US CDC. Any case of H5N1 is concerning because it's highly dangerous to humans, although it has never been shown to be easily transmissible between people. WHO and our partners track influenza viruses globally to monitor the evolution and spread of viruses in both animals and humans. Finally, this Sunday marks World Health Day, the 76th anniversary of the Constitution of the World Health Organization coming into force. This year's theme for World Health Day is My Health, My Right, reaffirming what WHO has affirmed since its birth on the 7th of April, 1948, that health is a right for all people, not a luxury. In fact, the WHO Constitution was the first instrument of international law to affirm that the highest attainable standard of health is a fundamental right of all people without distinction. Today, at least 140 countries recognize the right to health in their own constitutions. And yet, around the world, that right is often unrealized or under threat. At least 4.5 billion people, more than half of the world's population, are not fully covered by essential health services. And 2 billion people face financial hardship due to out-of-pocket health spending. Outbreaks, disasters, conflict, and climate change are all causing death and disability, hunger, and psychological distress. Realizing the right to health means passing and implementing laws to ensure people can access the health services they need, where and when they need them, without financial hardship. It means addressing the reasons people get sick and die. It means safe drinking water, clean air, and good nutrition. It means quality housing and decent working and environmental conditions. And it means freedom from discrimination. 76 years since our founding, WHO remains totally committed to the highest attainable standard of health as a fundamental right for all people everywhere. This World Health Day, we call on all people to demand your health as your right. Della, back to you.
Thank you, Dr. Tedros. I will now open the floor for questions from journalists. If you want to ask a question, please raise your hand using the raise your hand icon and unmute yourself. We will start with Helen Branswell, Stat. Helen, can you hear me?
Yes, thank you very much, Fadela. My question is about the H5 case in the United States. I believe the last risk assessment that WHO conducted on H5, particularly the 3.4.4.4b clade viruses, was published in late 2022. Is WHO going to undertake an updated risk assessment of that clade of viruses, please? Thanks.
Thank you, Helen. I would like to invite Dr. Josh Mott, Senior Advisor, Influenza and Pandemic Preparedness, to answer your question. Dr. Mott, can you hear me?
Yes, I can. Thank you, Helen, for the good question. Currently it is the 2.3.4.4b virus that is spreading globally. As you know, it emerged in 2020 and spread globally as a virus in many animals, but then it spread to aquatic and terrestrial mammals as it spread, including in the United States. That virus has infected cats and dogs and other mammals, and now more recently, cattle and goats as well. And as you know, the recent case has been associated with infection in livestock and conjunctivitis in a dairy worker. What we know so far is that the virus itself has not changed substantially from that which we have seen spreading globally. We do know that that virus has been adapted to mammalian hosts in some capacity, but has not shown any signs of spreading efficiently from human to human. And so for that reason, at this point, we have not seen a change in the virus. We'll continue to stay in close contact with the WHO Collaborating Center for Influenza at CDC and with our colleagues at the Regional Office for the Americas at PAHO to continue to assess the situation. The investigation's ongoing. We're looking at the changing epidemiology and make decisions as we go. Some things that we're doing to be prepared, of course, though, are to look at the current candidate vaccine viruses for H5 in case it were to spread in humans. Do the current viruses that we have, would they work for a pandemic vaccine? And we can say that right now for this virus, they currently would, and it responds to antivirals as well. That on top of making sure that surveillance is as good as it can be globally is what we're doing while we assess the situation and then determine any future need for more risk assessments.
Thank you so much, Dr. Mott. I would like now to invite Belisa Godino, W Magazine, to ask the next question. Belinda, can you hear me?
Hi, thank you for taking my question. I'm Belisa Godinho from W Magazine based in Portugal of Global Broadcast. My question is, how is emergency medical assistance in the conflict between Ukraine and Russia going? Anything new to highlight? Are human rights being ensured? Thank you.
Thank you. Mike? Mike, Ryan will take your question. Thank you.
Yeah, we continue. The Ukraine remains one of our largest operations in the world, and along with our operations in Gaza and in other places around the world. We're working very, very closely with the Ukrainian health authorities to ensure that the health system can emerge and be strengthened out of this nearly 3 years of war right now. There has been deterioration in the health system. There has been degradation of the health infrastructure. And we still require all parties in the conflict to provide unhindered humanitarian access, and particularly in areas close to the front line and to those under temporary military control. We need to be able to meet people's needs in those conflict zones. But the whole health system across Ukraine has been put under pressure. It's remarkable to have seen how resilient that system is, how resilient health workers are. But the prolonged war continues to bring new challenges, and it continually tests the system's capacity to respond. Insecurity and access challenges are continuing to hamper assistance in areas under military control, as I said before. And our assessment, the current assessment, remains the same. About 40% of the population of Ukraine still require some form of humanitarian assistance. The 13.6 million displaced people, displaced Ukrainians, 6.4 million individual refugees have been recorded globally. So there is still a huge displacement phenomenon. There are still many, many Ukrainians displaced outside the country as refugees, as I said. When we've done needs assessments on the front lines, it's very, very clear that a large proportion of people lacked primary healthcare access. People with chronic conditions and children are facing problems in accessing healthcare. Attacks on healthcare have been the highest we've recorded in any particular conflict. We've verified a total of 1,682 attacks on healthcare since the beginning of the war. 1,461 of those affected healthcare facilities and 384 impacted health supplies. We continue to monitor the situation at the Zaporizhzhia nuclear power plant, and we have an emergency appeal out there for $112 million to cover the requirements for healthcare support to the population of Ukraine through the Ministry of Health. So, testament to our team on the ground, to our partners in the health cluster, to our partners in the emergency medical teams, and to those who funded this response. So the needs are still great. The health system is exceptionally fragile. The health workers continue to make this system work, and WHO and its partners continue to support those health workers and that health system on the ground.
Thank you so much, Dr. Ryan. I believe Dr. Zakaria Teresa would like to add some details. Dr. Zakaria, you have the floor.
Thank you very much, Fadila. On Ukraine, yes, just to also build on what Mike has mentioned, this is one of the emergencies where WHO has actually managed to leverage the strength of the national partners, so national organizations inside Ukraine, to scale up the provision of emergency health services to the population in need of such services. In this year, WHO is helping to coordinate 91 health cluster partners. The majority of them are national partners, and they also include national EMTs. This is a good practice that we're also trying trying to replicate to the extent possible in other settings, including in Palestine, where national capacities exist and they can continue to be built up so that national emergency medical teams can be as performant considering their advantage as well in terms of familiarity with the populations and the context. I think I would also like to highlight here that Ukraine, as Mike mentioned, has still a tremendous health needs. The health system remains resilient, but requires help, and the longer it is under pressure, then the more eroded its coping capacities become. Ukraine is at the moment funded at 24% of the financial requirements, and it's really far from what we need to properly respond to the need of the populations. But this is also to highlight that unfortunately across the world, this is what we are seeing: less and less financing to respond to the urgent health needs of so many millions of people affected by various humanitarian emergencies. Thank you, and back to you, Fadila.
Thank you. I would like now to invite Mohammed Arslan from Anadolu to ask the next question. Mohammed?
Yes, thank you, Fadila. As you mentioned, there is an unsafe environment for healthcare workers in Gaza right now. My question is, how many staff WHO does have there now, and does WHO have safety concern for its staff? And the last question is, have you considered any measure to ensure that your service will continue to reach Gazan people? Thank you.
Thank you, Mohammed. I would like to invite Rick Peppercorn, Dr. Rick Peppercorn, WHO representative, to take these two questions. Dr. Peppercorn, you have the floor.
Thank you very much. And good afternoon to all. I think that the question is twofold. So first of all, yeah, we have a very strong team in Gaza with approximately 7 internationals and currently like 16, 17 national staff operating. We are there to stay and deliver as good as possible. We are actually recruiting more staff. Probably at the moment we actually have 20 national staff because we're recruiting more staff. Some of our staff are now also Gaza staff are now based in Cairo and assisting us as well. We are there, of course, to stay and deliver. Now, you mentioned something about the security and security concerns, and I think the DG, I think, rightly highlights why we are all appalled by the killing of the 7 WOCK humanitarian workers, our colleagues, in clearly marked vehicles. Actually, I know that area very well, in a deconflicted area. So what it shows that a deconfliction mechanism is not working, and maybe I want to say something about that. So the UN and partners, when you need to be able to deliver aid throughout Gaza. So what is needed is an effective, transparent, and workable deconfliction and notification mechanism. So UN has to be assured that convoys and facilities are not targeted. It means that ensuring movement of aid within Gaza, including through checkpoints, that it is predictable, expedited, etc. Roads are operational, that roads are cleared, etc. Now, just to repeat, when the DG also reflected on Shifa. So since the last siege on Shifa, it was a couple of weeks ago, WHO organized 6 missions to do 3 tasks: to make a quick assessment, discuss with the staff, make a quick assessment, and to assist the patients to being referred from Shifa to Al-Ahdi Hospital and staff, and to make sure that the patients in critical conditions, a triage would be done, and to take them to the south of Gaza. 6 times those missions were denied impeded or delayed. And so it's not functional. And even today, the WHO, my team, was in a mission to the north again to deliver fuel and medical supplies, food and water to Al-Ahli Hospital and Sahaba Hospital in the north, and to help with referral from some patients. They were, as was planned and agreed on, between 6 and 7 ready to go. They went to the checkpoint just before the checkpoint. They've been waiting and waiting and waiting up till now. Now they had to return back. As we speak, they're returning back to their guest houses. So again, we see way too many missions impeded, delayed, or denied. And it's not only about these missions, a whole day in that AV, etc. But it's also making the missions which are delayed, and I've been on quite a few myself, they're becoming more arduous and dangerous. You sometimes return 11 o'clock at night or midnight or even past midnight. So it becomes unnecessary dangerous. And I want to say something about that too. This is not the first time, this horrific attack on WCK. We shouldn't forget that already in December, January, we have seen, unfortunately, attacks and sometimes a shooting at UN vehicles, and including, I remember I was in a mission myself in early December to the north to Al-Ahli, and there was an airstrike just 150 meters from our car. The truck delivering medical supplies was shot at, the PRCS vehicle was shot at, and PRCS staff were actually arrested and detained for a while. So all of that makes, of course, a humanitarian operation extremely difficult. And this is what we expect, a functional and a workable deconfliction mechanism. And that means a mechanism all over Gaza and not just to the north, for all over Gaza. Over to you.
Thank you, Dr. Pieperkorn. I would like now to call on Robin Millar from AFP to ask the next question. Robin?
Thank you. I'd like to ask a question on the pandemic accord negotiations. Countries failed to reach an agreement on time before Easter, and are going to come back at the end of April for more talks. So in the time between now and then, what do you want to see countries do in order to try and bridge those gaps that still remain? Thank you.
Was it clear, or should I have said something about Shifa as well?
Dr. Pieperkorn, can you unmute yourself, please? Mute. Mute yourself, please. It's done. Thank you. Thanks so much.
Yeah, thank you very much. I think the negotiation that started a few months ago is continuing. I don't think that what's happened in last INB could be qualified as failure, but this is a continued process that member states are taking to negotiate and to come up to consensus. What the INB asked for is they mandated the Bureau of the INB to come up with new iterations for discussion and negotiation in next INB on 29th of April. But also they asked the Bureau to organize several informal meetings before that, before sharing the text, and also after sharing the text. And the Bureau is planning and organizing several informal meetings with key proponents of the negotiation, but also with the regional groups and also with ambassador in Geneva. The aim is to seek advice from member states on what are the key issues that need to be reflected in the new iteration, but also what are the areas where there is a potential agreement, or what are the areas where we need more work. And this preparatory meeting that the Bureau is planning will be extremely helpful in first coming up with the new draft that is a good step forward to reach a consensus, but also to seek the advice from the member state on issues that we'd like to see in this text. I think we are very hopeful and we are optimistic that in the next meeting the member state will get there. I think the only challenge that they have now is the how to deal with this great big amount of details that they are in the compilation text that reflects all member states' input. But I think the Bureau is working on that to come up with more streamlined version that concentrated key issues and also the most important things to come up to discuss now, agree on now, and maybe reflect on issues that need further work after the deadline of May 24.
Dr. Tedros?
Yeah, thank you. On the pandemic agreement negotiation, one, there is progress already made until the last meeting. And second, there is commitment by member states to have a deal by May 2024. And third, they know their respective positions now with the remaining issues where they have not reached a consensus. And that means, I think by the time they come back, they will be ready to give and take. So considering all these three, our understanding is, as Dr. Mahjour said, there could be a deal. That's what we expect, given the current situation. I have tried to participate or to attend many of the meetings in the last round of negotiation, MB9, and what I have seen is encouraging, and I hope they will reach a deal by May 2024. Thank you.
Thank you, Dr. Tedros. I would like now to call on Abdul, a reporter for The Guardian. Abdul, can you hear me?
Hi, can you hear me?
Yes, please go ahead.
Thank you. Sorry, it's Geneva Abdul from The Guardian. I just have a question with regards to the comment that was made that the current deconfliction mechanism is not working. What are the repercussions the WHO foresees that will result from this, both for medical workers in Gaza, but also those in need of aid? Thank you.
Thank you. I believe we still have Dr. Peppercorn. Dr. Peppercorn, can you hear me?
Yeah, I can hear you. Yeah, I will try to. So I think I try to be clear on that. And a good deconfliction system is that you agree that the UN, I'm talking now for the UN and partners, that you agree, first of all, we prepare a mission every time in Gaza, whatever mission it is, food delivery, if it is medical supplies, it doesn't matter if it is WHO, WFP, or UNICEF, you prepare a mission, which is a lot of work. And all the details are shared through our Israeli counterparts. The timing, where to, etc., including the people on the missions, etc., all the staff, etc., is done. Then there's an agreement. There's a green light that, okay, that mission can take place from this hour. You want to start as early as possible, and for some of the food transport, my colleagues in WFP can be clear, it's even better to do that at night, actually before the sunrise. But I say with medical supplies, etc., fuel, what we do, medical supplies, fuel, food for patients, etc. We normally start a mission around, we gather around 5, 6 in the morning, 6 o'clock. And we should start at 6 o'clock because there will be always delays and you want to be back in daylight. That's one. So there's an agreement then that you report and you will get a green light again around 6:30, 7 o'clock. That's where it starts. Then normally there's a holding point at the checkpoints, the military checkpoints. You have to wait. Again, discussions, etc. Normally, I had a few smooth missions, but most of the missions were always problems. There were always delays. and often denials in the end, or even before that we submitted the mission and it was denied for very often completely unclear reasons. But if you've agreed, you stick to it. And what I said, the mission of today is a good example to bring fuel, medical supplies, food and water to those two hospitals in the north. It was all agreed that they would leave 6:30, 7 o'clock. Then first of all, they don't get a green light to go. Then finally, they get a green light to go to the checkpoint. They go to the checkpoint, and with food, it's always risky. I must say, all those missions have their risk as well, with so many people desperate. Then they had to wait before the checkpoints, and they wait and they wait and they wait. In the meantime, very little discussion, nothing is going on, etc. And at one stage, so they already realized if we get the green light now, we cannot go to Sahaba anymore. They already changed their plans. They would only deliver the supplies to Al-Ahli Hospital and then go back. But now it took so much time, and finally it goes over, so they will never be able to return, and they have to cancel the mission. So what is a workable deconfliction mechanism that routes are coordinated, cleared, that it's predictable, a predictable mechanism, and that we ensure that also the roads are cleared, which are going to be taken, and that there's multiple entry. And it is not so difficult. I mean, anyone who knows Gaza, there's a number of roads which can be easily cleared and made operational. And there should be 15 missions going to the north every day. Multiple food, water, shelter missions should be going, and maybe one medical mission every day. That should be happening, including everywhere in the south. It also will means roads should be cleared, and unexploded ordnance should be removed. And these missions are also complex because also from the UN, you need to have a security officer with you, which are often rare, etc. You would like to have even somebody who recognizes unexploded ordinances with you in the team, and then of course your team lead. Now it's an enormous amount of work, and every mission which gets delayed or impeded or denied means, and I think the DG was pointing that out, that other missions cannot take place, so that we cannot do other priorities. So in a way, it's a simple mechanism, and somehow it has never properly worked. It's, yes, we have had many missions, but it never properly worked. And we have, I think, on this former press conferences in January and February, I think we made a point that from the 20 missions we actually asked for the North, I think something like 14 or 15 were denied, impeded, not happening. That should not happen. Those missions, and even, I want to make the point, even if there's an active conflict going on, then you expect that humanitarian corridors are created. Humanitarian corridors where the humanitarian partners, UN and partners, can safely deliver their aid and do their job, make their assessment, deliver it, and come back in time. And clearly, the horrific attack on WCK is clearly a sign that it was, of course, absolutely not working. And I just wanted to make the point that we have had incidents in the past, and the UN has repeatedly reported on those incidents. Should not happen. So I really do expect, whatever comes out now, that we get a functional deconfliction mechanism and a proper notification system, and that the UN and partners can do their work. And I just want to say that we are here, and we are here to stay and to deliver. Maybe one last point I want to make, because it's close to my heart, and the DG was referring to Shifa, Al-Shifa Hospital, and currently, as we've all seen, non-functional. And indeed, for anyone who knows it, it was the beating heart of the Gaza health system. I mean, we talked about 17,000 operations annually. 750 beds. I mean, a dialysis department with a capacity of 52 beds, a central lab for the Ministry of Health, but even maybe more important, it was also a teaching hospital. Hundreds, thousands of young student doctors, nurses, midwives, etc., lab technicians, residents, etc., were taught there and got their training. And this hospital not being functional, and the other, the second largest referral hospital in Gaza, the Nasser Medical Complex in Khan Yunis, at the moment also not functional. We've reported on the missions there. I just want to stress that point. So we, WHO, will help to make these key health institutions functional again, because it's needed. Those two institutions are absolutely needed in Gaza, and we will make that happen too in the future. Thank you very much.
Thank you, Dr. Pieperkordt. Dr. Mike Ryan.
Yeah, I just want to speak to this because there's maybe an impression that this deconfliction thing is something that's just started in this conflict and it's not working because it's new to us. We've been doing this for decades. And you ask, you know, humanitarians and militaries aren't necessarily have the same objective. What you need in order to have deconfliction is that the military and the humanitarians do have the same objective. We have different objectives, but we have one common objective in a normal situation where people are abiding by international humanitarian law, that the humanitarians and the military authorities are both occupied with the protection of civilians and the insurance of continued humanitarian assistance despite the conflict. I won't say whether a conflict is justified, not justified, right or wrong. The issue is that a responsible military operation will always seek to protect civilians and ensure that they have access to the basic necessities of life: shelter, food, water, and medicine. That's why we can work with military authorities, and sometimes not formal militaries, sometimes anti-government elements, and sometimes organizations that don't have tremendously rigid or strong military structures, because we agree on that principle. And when we agree on that principle, we as humanitarians can disclose very sensitive information to those militaries. We can tell them who that we are, where we're going, what we're taking, how long we will be, so that they can use their military tactics to avoid attacking us so we can serve the people. That is a common objective of a responsible military acting responsibly in a conflict for which they believe they have a justification to carry out. That is not my choice to make, but it is the responsibility of all combatants in a military conflict to abide by the international humanitarian law, which is to allow access for humanitarians to the population who are at risk, and to ensure that the access for those humanitarians is planned, guaranteed, and supported. That's international humanitarian law. That is the expectation, and deconfliction works when both parties, the humanitarians and the military, observe and are obsessed with that same objective, to ensure that the civilian population receive the care that they need. And in that sense, we as humanitarians disclose a lot of information, because telling someone where you are in a conflict puts you at risk. Telling someone what road you're using puts you potentially at risk. We do that in order so the military know where we are. We can't assume all the time that the military will know where everyone is. We want to avoid accidents. We want to avoid any problems by letting them know. And Rick outlined that process day to day. There's a huge overhead in doing that, because it's exhausting to do that every day. And to be able to, and the problem is, and we've said this way even before January, Rick, you were saying January, back last year, in November, WHO was clearly stating that the deconfliction system wasn't working. We were telling the world that it wasn't working. It's clearly not working. And our staff and our partners are in danger because of it. And something needs to be done to ensure. We would like, as Tedros said, the conflict must end. Hostages must be released. We need peace. In the absence of that peace, we need deconfliction, and we need humanitarian access, and we need humanitarian corridors. And in protecting those health workers by providing them with medicine, and Rick spoke to that in his intervention, I'd just like to link the two ideas. We have the treaty, or the accord, or the agreement coming up, which at its heart is about protecting populations, but within that protecting health workers. And now we have a problem in conflict where it's difficult to protect health workers. At the consultation between the Bureau of the IMB and civil society and non-governmental organisations, Pedro Bilardi from Public Services International spoke eloquently about the need for this agreement in order to provide the basis of protection for our health workers who suffered so much, sacrificed so much, gave so much, their lives in the face of COVID. They're doing the same thing in Gaza. Our health workers are offering up their very lives to support the populations they serve. Both our health workers and the agreement of an accord and the health workers who serve in Gaza deserve our protection, our collective protection under international law, be that in an international agreement for the next pandemic, or be it through the proper application of international humanitarian law, which already exists. So we call out to all the member states, please ensure that IHL is respected and that deconfliction measures are demanded by the international community, especially now in the case of Gaza.
Thank you. I would like now to invite Gabriel Tetro-Farber from Reuters to ask the next question. Gabriel?
Thank you, Fadela. I'd like to ask about Al-Shifa, if possible. It's been described as the heart of the health system in Gaza. And for months, we've been saying that Gaza couldn't afford to lose another health facility. What happens now when you lose such a massive referral center? And what are the odds you think you have to get that mission authorized from the Israeli authorities in terms of making an assessment of what can be done for the remaining patients on the ground? Thank you.
Thank you, Gabriel. Dr. Pieperkorn?
Yes, thank you. It's a very, very focused question. Well, first of all, I think, yeah, we definitely need a Shifa or what I say, national medical complex. And I think we all will realize that the current healthcare providers is insufficient and absolutely not of the quality you would like to offer to anyone around the world. Also realizing that Gaza had a relatively, I wouldn't say fantastic, but okay functional health system before this crisis. And again, producing health indicators at par with its neighboring countries. And yes, struggled somewhere in quality, primary healthcare, mental health, etc. And some of the with no proper oncology. WHO, we wanted to assist with actually setting up a cancer hospital in Gaza. But overall, it was working well. So there is this huge group of very well-trained health workers, which we estimate probably a quarter, a third, maybe a little more, a little less, are still operational. So you ask where. So what is done is a little bit what is done, I think, in every crisis of war. So which hospitals are still operational? And we have seen this over this last 6 months. That, for example, when you look at the north, we have hospitals like Shifa, which was non-functional at one stage, and then it became functional again with a lot of support from WHO and partners. It again became functional, and not as a third-level hospital, but definitely as a first-level hospital. Actually, when we talked about a couple of weeks ago, 6-7 weeks ago, and I was again in Gaza, then Shifa was still again a little bit. It was still again the referral point for trauma cases in the north. Now that's now again lost. Yeah, maybe I'm too hopeful, but I also always think we should look at the possibility to have at least a functional unit there, definitely trauma support unit, primary healthcare unit, and look what is possible, but you need access for that. There's other hospitals in the north which have had different. We talked about Kamal Adwan, we talked about Al-Ahli. Al-Ahli was a relatively small hospital and became relevant because other hospitals became partly functional, non-functional, barely functional, etc. And Al-Ahli, but also Al-Ahli, when I was there early December, was completely overloaded, and then actually late December it was non-functional. It was besieged. Health workers left, etc. Health workers came back, etc. And it's now again partly functional. And WHO and parts, we help Al Ahli Hospital. So we will have to do. Gaza will have to do with a number of hospitals in the north. Now, in our discussions with our Israeli counterparts, they have informed us they want functional health in the north. So we will push that agenda. And again, we have been able to sometimes bring supplies when we have reported on the many missions we did. We want to do much more. And we don't want a mission like today to be cancelled or delayed or impeded and not happening. So yeah, we will have to work with a number of these facilities and see what we've done. That also applies for the south, where we shoot at south of Wadi Gaza, where approximately 1.9 from the 2.3 million people reside. That's even more important now, like which are the hospitals which are functional, and then losing Nasser Medical Complex is of course a huge blow. A huge blow. It means much more work for the European Gaza hospital, which is completely overwhelmed, and Al-Aqsa hospital, which are now the two referral hospitals. And a hospital in Rafah itself, Al-Najjar, which used to be not a referral hospital, but is currently operating as a referral hospital. There are a few field hospitals, which is IMC, I think, which is doing a fantastic job as well, and even taking some of the referral cases. But even then, even IMC relies on, for example, European Gaza to hospital to refer patients and more complex patients, and they don't have all the medical equipment for that. So it's really, and I would say it's a complex, but I'd say overall, we have to recognize that absolutely insufficient healthcare is provided in Gaza. It's a health system on its knees, that has been said so often, and it is. It's insufficient, it's incomplete. WHO part, we're also trying to help the primary healthcare system to revive that. UNRWA, I want to mention UNRWA there is doing a fantastic job in actually making sure that their primary healthcare clinics are continuously open, and we are also happily supporting and working with that. So we've always made the point that we want to expand the current system, and expand it with emergency medical teams. There's a number of emergency medical teams operational, and in specifically south of Wadi Gaza. We were bringing in the first. We're planning to bring in the first emergency medical team in the north, in Al Ahli Hospital. That has happened. We had plans, of course. If you would ask me that 6 weeks ago, we were planning to, when we were helping to revive Shifa, to get an emergency medical team in Shifa. All those things can only work when there is a certain level of security. I mean, of course, we all want a ceasefire with a certain level of security. What I can say now about Shifa, that indeed thousands will be left without healthcare. They will have to move to places in the north, to Al Ahli, to Kamal Adwan, to Al Hilu, which is a very small hospital, which has also struggles to remain open, and to places like that. Over to you.
Thank you, Dr. Pieper-Kohn. We have come to the end of our press briefing. Thank you all for your participation. You will be receiving the video and audio files of this press conference shortly, and the transcript will be available on the WHO website. And of course, we will be sending you Dr. Tedros' opening remarks. I would like also to let you know that just after the closing by Dr. Tedros, we will have a short video to show about World Health Day. So before we show the video, Dr. Tedros, if you want to close this press briefing.
Yeah, no, thank you. Thank you. I would like to thank the members of the press for joining us today. Maybe to add a few lines to what Rick had said on Shifa Hospital. I visited Shifa Hospital in 2018. Even then, although the service it was providing was okay, but it had problems, and it was serving with its problems, and because of the siege even then. So what will happen now with Shifa gone? I think, as Rick said, many will not be able to access services like what they were getting in Shifa. But not only that, people who need medical evacuation will increase. And medical evacuation is already slow, but I think the number of people who need will increase, of course. And with a slow evacuation, meaning, I think you can guess, people will die because they will not get the services either from Shifa or because of slow evacuation, because they cannot be evacuated. So that's why at least the process for the evacuation has to be expedited, and people who need medical evacuation should be supported elsewhere. Otherwise, we will lose many people. We will lose many lives. Again, to the press group who joined today, thank you so much, and see you next time. But please don't go. We invite you to watch the video. Thank you.
Her asthma, it's getting worse.
We can't help you here.
We can't help you now.
Come back next week.
Can someone please tell me what's going on? You must pay cash to be admitted.